Medurstand Understanding Medicine.
I'm Professor Aziz Rehman, and today we're going to talk about this very common and very sensitive problem many men suffer from, but they are unable to talk to the doctors, and doctors do not usually encourage the people to discuss about their personal issues, and the problem remains undiagnosed and also untreated. Unfortunately, the treatment was not available till only recently, although this Sildenafil, which is a phosphodiesterase 5 inhibitor, which is the main treatment of erectile dysfunction, is available in the world since 1998, but only I think last year it became available in Pakistan. So with the availability of these drugs, physicians have started talking about this problem, and patients have also started discussing this issue, and now we are treating. So that is why this lecture has become relevant. And now this lecture would be divided into two parts. In the first part, we will discuss the physiology of erection and pathophysiology of erectile dysfunction. And in the second part, we will discuss the assessment and evaluation, the treatment. Please, if you watch this video, please watch the other one also. Only then you will have the complete concept. So in the first part, physiology and pathophysiology. Physiology of erection is very interesting mechanism, and I think one of the most genius principle used by nature. First of all men's sexual disorders are not actually erectile dysfunction. This is the spectrum of male sexual disorders. Just briefly, erectile dysfunction, which we are going to talk about today, and premature ejaculation. It's ejaculation that always or nearly always occurs prior to penetration or immediately after penetration, the vaginal penetration, within 1 or 1.5 minutes. So that is called premature ejaculation. Many men are suffering from premature ejaculation along with erectile dysfunction. Then delayed ejaculation. This is usually the effect of some drugs, marked delay in ejaculation or infrequency, absence of ejaculation. That means patient is exhausted during intercourse, but the ejaculation doesn't occur, the orgasm doesn't come. Then hypoactive sex desire disorders, and this is persistently low or absent sexual desire causing distress, and this is actually also called loss of libido. Libido is the desire of sex. All men and women, healthy men and women, they have this desire of having sex, but if that is lost, the problem is either related to brain, or patient may be taking some antidepressant drugs, because most men and women, they have intact desire. Usually a systemic disease, a severely disabling disease, or heavy medication can suppress this libido. Of course, with the age, it gradually declines, and there may be age when there is complete loss of libido. Then male orgasmic disorder. Orgasm is the climax of sexual function. Delay in infrequency of or absence of orgasm after a normal sexual excitement phase. So erection occurred, but the orgasm did not come, and the ejaculation did not follow. Then Peyronie's disease. This is actually an anatomical abnormality of the penis. There may be fibrosis, the deformity, the penis may be curved, and there may be some pain during intercourse. So patient might avoid intercourse. So it is not truly speaking erectile dysfunction, but this is one of the sexual disorders. So we will be actually talking about this erectile dysfunction in more detail. What is definition of erectile dysfunction? The consistent inability to achieve and or maintain an erection adequate for satisfactory sexual intercourse. This is the NIH consensus panel's definition. But I think several words require elaboration. It has to be consistent. Just one episode, there may be some circumstances where one may not get erection because of the circumstances. but it has to be consistent, that means more than once, to achieve or maintain. First of all, to achieve the erection, and then to maintain it for sufficient time to make the intercourse possible. And the word satisfactory, that means there may be people who have the erection, they have intercourse also, but they're not satisfied with the level of erection they have. So all these things make it a relative thing. I mean, it makes a relative thing. Some people may think that they have erectile dysfunction, but actually they may still be able to perform sex. So I think if somebody comes with this problem, I think that means the problem is sufficiently severe that this requires attention. So patient's description of the problem would be diagnostic. So the definition is simple, but the condition is not. Now, this is a famous saying by Leo Tolstoy. This is often quoted and attributed to Leo Tolstoy. Frankly, I could not confirm the originality of this statement, but this is what is quoted. Man survives earthquakes, experiences the horror of illness, and all of the tortures of the soul. But the most tormenting tragedy of all time is and will be the tragedy of the bedroom. So if a man is unable to perform sex, that would be very traumatic for that man. So if this is consistent, that would actually affect one's personality. A man might not feel himself as a man if he is unable to perform this intercourse. So I think this statement might not be made by Leo Tolstoy, but it is actually a fact that men take this issue very seriously. They take it to the heart, and it often manifests in some psychological distress. And of course, it relates to relationship problems also. Now, this is the anatomy of penis, and both flaccid penis and erectile penis. This is the bladder. You know the prostate, urethra is passing through this, and this is the pelvic floor and the penis. And this is urethra passing through. And cut section, and this is flaccid urethra, and you need to understand this anatomy. Only then you will be able to understand the pathophysiology. Now, there are two, starting from here, we have dorsal nerves, which of course carry the sensations, including the sensation of orgasm. Dorsal arteries, two dorsal arteries which supply the blood, which is very much required for erection. Without blood circulation, there cannot be erection. In fact, in some cases, the reason of not having successful erection may be problem with the arteries. Deep dorsal vein, this is the which drains blood out of this penis. Corpus cavernosum, this is a structure, there are two of them, a structure which consists of multiple spaces which are normally collapsed. They are potential spaces, but on erection, the muscles, the smooth muscle, which are the walls of these cysts, they relax, and trabeculae, I think they call trabeculae, and these spaces dilate. And then we have a urethra and the corpus spongiosum. So erectile dysfunction occurs when the problem is with the arterial supply or the vasodilatation or the trabecular dilatation. Now this is the normal function, normal erectile penis. You can see these sinusoids are much bigger than this one, and the corpus cavernosum is also much bigger, and you know that these are filled with blood. And in subsequent slides I will show you how this all occur. So you have a close-up, you need these spaces which are normally just potential spaces. They dilate and then they are filled up with the blood, and there could be actually pressure of up to 100 millimeter of mercury. That keeps the penis stiff, and it stays for some time. After the sexual activity is over, then everything gets reversed. So normal sexual function, first of all, you need to have libido. You have to have a desire of having sex. Then there is a stimulus, because the desire is then in the background. And then there is a stimulus, and this stimulus could be visual. I mean, if one sees a sexually erotic object, or it could be tactile, like for example somebody masturbates, or it could be olfactory, or it could be auditory, and usually multiple actually factors. So these factors, they stimulate or make you ready for the intercourse, and this phenomenon is called arousal. So in the background of libido, with a certain stimulus, you become aroused. That means mentally and physically you become ready to perform sex, which of course has got a number of ways. You may feel little blushed also, maybe it's a little more circulation in the head, little throbbing, little palpitation, and also the erection. So this erection is driven by parasympathetic nervous system, and the mechanism I will explain to you later. And then there is intercourse. Usually after erection, one has natural intercourse and or masturbation, and that culminates into orgasm. Orgasm is the climax, at the last moment, and there is usually escalation of certain sensations which are very pleasurable, and then they reach the peak, and then there is ejaculation, and then the feeling then suddenly subside, and this is called orgasm. And of course the intensity of orgasm can change. Younger people have more intense orgasm, and the elderly people have less intense orgasm. And this is then ejaculation. Ejaculation is momentarily, expulsion of the semen, which consists of many substances actually, which is comes from the testes or from the prostate and the seminal vesicles. So total semen, which is about 3 to 5 ml, that is ejected. And then of course the sexual activity occurs, that leads to detumescence. That means that there is sexual activity is over, and this is driven by these two, the ejaculation and the detumescence is driven by sympathetic nervous system. So parasympathetic nervous system and sympathetic nervous system, both belong to autonomic nervous system. They play their roles respectively. Initial part by parasympathetic nervous system, and the later part by sympathetic nervous system. Both are important, because once sexual activity is over, then of course penis has to go back to its normal flaccid state. Then there is the refractory period. Now of course one can have sex multiple times, but usually one is not ready to go for another round immediately after the first one, and this is again age dependent. I think younger people can have another intercourse within minutes, and elderly people would require more time, and maybe sometime a day or so. So, and then you have libido, you can perform sex again depending upon the stimulus. I think more than 2 or 3 would be very unusual, but usually it's one round. So we are going to discuss this erection problem, which is driven by parasympathetic nervous system. This is the total sexual activity, but I think we are going to now more concentrate on the erectile dysfunction, and we are going to talk about the erection. So this is the flaccid penis. You have dorsal arteries, vein, and corpus cavernosum, and then there's a stimulation. First of all, stimulation, and this stimulation is driven by non-adrenergic and non-cholinergic mechanism, and this is actually part of sympathetic nervous system. And there is release of nitrous oxide, and you know nitrous oxide is actually, I think somebody won the Nobel Prize on discovering nitrous oxide. It has got various functions in the body, and one of them is this erection. There is production and release of nitrous oxide by the nerve endings. You know, the pudendal nerve and other nerves, they come to the penis, and they are then on the arteries, arterioles. This nitrous oxide is released, and nitrous oxide is a very potent vasodilator. immediately, because a spurt of nitric oxide comes and it immediately dilates all the arterioles of the corpus cavernosum. And this is actually, then this nitric oxide stimulate the release of cyclic GMP. Cyclic GMP causes arterial vasodilatation. Nitric oxide is the trigger, but it is through cyclic GMP which is responsible for arteriolar vasodilatation. So the diameter of arterioles may increase several fold. Not only this, there is actually trabecular smooth muscle relaxation. These cavities are actually called trabeculae, and their wall has smooth muscle. Normally they are in the contracted state, and so the spaces are actually potential. But once there is arterial vasodilatation, lots of blood pours into the trabeculae, and these gets dilated because of the muscle relaxation. Both are triggered by cyclic GMP, and in the background the stimulation of nitric oxide. And then interestingly, as the pressure builds up, there is something called tunica albuginea. This thick layer surrounding corpus cavernosum and corpus spongiosum under the skin is a thick layer, and this would not allow it to expand too much. So these veins, small veins, can you see these small veins which drain blood out of penis? They are compressed. So again, nature's wisdom. On one hand, arterioles which bring in the blood, they are dilated, and the veins which take the blood out, they are compressed. So the pressure builds up in the penis, and that leads to erection. And then once erection leads into the intercourse or ejaculation, then cyclic GMP is degraded by an enzyme called phosphodiesterase 5. Phosphodiesterase 5, actually there are various types of phosphodiesterases, but the type 5 is mainly responsible for the degradation of cyclic GMP, and then that would mean there is detumescence. So this is how things happen. Very interesting. Most importantly, nitric oxide and cyclic GMP, they play their role. And where this phosphodiesterase 5 inhibitors work, it is here. They actually prevent degradation of cyclic GMP. So once you have taken phosphodiesterase 5 inhibitor, then degradation of cyclic GMP will be slowed down or delayed or prevented. That means this process will remain for longer. So arterioles will remain dilated for longer, and trabecular muscles will remain relaxed for longer, veins will remain compressed for longer, and erection will last longer. But you have to come to this point on your own. So you have to have intact libido stimulation and then erection. Only once you get erection, only then phosphodiesterase inhibitor work. This is actually, I think, in a way a blessing, because if these drugs cause erection when you're not stimulated, that would be actually a source of embarrassment. You may be in a place where you're not ready for sex, but you have taken this phosphodiesterase 5 inhibitor, it might lead to inappropriate erection. So very, very interesting. Only when the circumstances are right, when you have libido, you have stimulation, you are ready for the sex, but you have taken phosphodiesterase inhibitor, only then you will have erection longer and more stronger. This is the same mechanism of erection in some more detail. This is the nerve ending, and this I told you, non-adrenergic and non-cholinergic. Normally these nerves, sympathetic and parasympathetic nerves, they secrete adrenaline or acetylcholine. But these are specialized nerves belonging to autonomic nervous system, but the specialized nerve endings, they end on the penile arterioles and in the corpus cavernosum. So once this is stimulated, nitrous oxide is produced, and nitrous oxide stimulates this enzyme guanylate cyclase, and that converts GTP into cyclic GMP, and cyclic GMP is responsible for smooth muscle relaxation and pouring of blood into the corpus cavernosum and erection. And once that is done, then it is destroyed by the phosphodiesterase into GMP, which is inactive. So the drugs, these phosphodiesterase inhibitors, they work here. And you also must know that phosphodiesterase 5 is only one of the many enzymes which cause deactivation of this cyclic GMP. Of course, this is the main one, but some other small deactivation is done by these enzymes also. But sildenafil is specifically inhibitor of this phosphodiesterase 5. So again, little revision. This is the flaccid penis, and this is the after erection. I have explained to you the mechanism of erection. You see the difference, anatomical difference, small cavities and the big ones, and dilated vessels and the filled with blood. And this is the mechanism of erection, and this is the cross section. I'll show you the linear also. So this is the one, this is a flaccid penis, and this is also actually not truly flaccid. This is also slightly erected, but then this is complete erected penis. So this is what makes this erection possible. Very, very genius and very, very interesting mechanism. I think I would call it like a foldable gun. You've never heard of a foldable gun, probably never thought of it. But this is like a gun which you unfold only when you want to use it. After using it, you again fold it and then put it aside. So this is very, very interesting mechanism of erectile function. And in my next lecture, I will cover some of the assessment tools and the treatment. Please join me in the next lecture to understand the complete module. I thank you for your patient listening. Professor Aziz Rehman for Medurstand-Understanding Medicine.